Well, first off, I'd like to thank Valerie and Bruce for inviting me to participate in this conference today. MetroHealth has a very long history and tradition of treating patients with malignant melanoma, really mainly because of Eddie Mansour, who was one of the very first true oncologic and melanoma surgeons in this area. And then 15, 16 years ago, he was joined here by Bruce Averbook, who came after finishing his training at the surgery branch of the National Cancer Institute with Steve Rosenberg, who is one of the pioneers in treatment of melanoma and one of the internationally recognized experts in the management of melanoma. So in the next 20 or 30 minutes, I'd like to give a bit of an introduction to the staging of melanoma to try to define the focus of this conference and hopefully serve as a platform for some of the subsequent speakers. I'll also review some of the clinical trials which are active here at Metro, and to briefly touch on some of the more standard therapies as well. So malignant melanoma, unlike most other cancers, is increasing in incidence. And indeed, over the past 30 years, the risk of an American developing melanoma sometime during their lifetime has gone from 1 in 250 to presently about 1 in 50. And in 2010, it's expected that at least 6,000 to 8,000 new cases are going to be diagnosed, and there'll be greater than 8,000 deaths due to this disease. The majority, fortunately, are localized disease, 85%. However, 13% of these tumors have spread regionally, and up to 5% have spread throughout the body or distant metastases. And the outcome that a patient may expect is really based upon the stage of the melanoma at the time of diagnosis. So the staging of melanoma actually is somewhat complex, but actually can be simplified down to standard terms, the so-called TNM classification. Okay, well, TNM classification, where T refers to the primary tumor characteristics, N if there is regional lymph node involvement, and M if there are distant metastases. And each of these characteristics is assigned a number. For T, 1 through 4, for N, 0 to 3, or M, 0 to 1. And the combination of those characteristics designate the stage. Now, some people like to get their pathology reports and read them, and the things that are important in terms of defining the primary tumor characteristics are the tumor thickness, whether it is a thin melanoma less than 1 millimeter, whether it's intermediate in its thickness, 1 to 4 millimeters, and whether it is a thick melanoma that is greater than 4 millimeters. Also, whether the tumor is ulcerated, and finally, the number of mitoses, or number of dividing cells that the pathologist can see in that in that tumor. The characteristics of the lymph node involvement that assign the number are whether the lymph node has no tumor in it, or there's microscopic involvement or macroscopic involvement, that is, something that can be seen without a microscope. Also, the number of lymph nodes involved, and whether or not the pathologist sees tumor deposits in the lymphatic vessels around the primary tumor. And finally, with distant metastases, what parts of the body are actually involved, and whether a blood test, the serum LDH, is elevated or not. Now, this cartoon is really aimed at trying to illustrate how tumor thickness really changes the risk of the tumor having spread. And here on the, I'm going to try my pointer again. Oh, here we go. Okay. So this is the thin or the skin in cross section, and here is a melanoma that arises in the pigment cells or melanocytes, usually in the superficial layers of the skin, and has a tendency to grow laterally, but at some point has the potential of starting to grow downward. The superficial layers of the skin have very few blood vessels or lymphatic vessels, and the deeper the tissue, the more lymphatic vessels and blood vessels that may be encountered. And so I think it's pretty logical to see that the thicker this melanoma is, the higher the probability it can invade blood vessels or lymph vessels, and thereby be able to spread from this original site. So what we're really going to be talking about today mainly is the stage 3 and stage 4 melanoma, where stage 3 melanomas are most simply defined as having spread to lymph nodes. And again, fortunately, this is the minority of patients, 10 to 13% of all melanomas. But the 5-year survival varies widely depending upon the characteristics of the lymph node involvement, and can vary anywhere from an expected 5-year survival of 20 years to as high as to 20% up to 70% 5-year survival. With stage 4 disease, where the disease has spread distally, again, fortunately, this is the marked minority of patients, between 2 and 5% of individuals. And this situation has a 5-year survival of less than 10%. Now, that being said, there are individuals who may have stage 4 disease, that the biology is somewhat unique, and some people can live for years and years with metastatic melanoma, but that's not the usual scenario. But clearly, with these kinds of numbers, major improvement is needed, and hopefully that's what we're on the path to do. Now, in terms of treatment of any kind of cancer, the available modalities include surgery, radiation, chemotherapy, or biologic therapy. And so all the permeations of various kinds of treatment really can be categorized within one of these modalities. And as I said before, what we're going to be focusing on today is the stage 3 and 4 disease. And also on clinical trials. That's the title of all the talks. And I just want to say a word about clinical trials because I think it's really important to kind of clarify exactly what this represents. A clinical trial is treatment that's delivered in a uniform fashion, that is by a recipe or protocol, to a large number of patients, maybe at different institutions throughout the country. And it's aimed at trying to answer a question by observing the outcomes of those treated patients. And these treatments are designed by experts and reviewed at multiple levels for both scientific merit and ethical delivery. And the final approval for a clinical trial is by an institutional review board that is made up of individuals, physicians, statisticians, clergy, laymen, all looking at whether such a trial can be delivered as safely as possible with the scientific background that the question being answered or asked can potentially be answered. The clinical trial is a mechanism that allows improvement in therapies while offering a chance at best or better treatment to patients, although the benefits and risks are uncertain. But all the advances that have been made in the treatment of melanoma and other cancers or through the conducting clinical trials. Okay, so let's look at stage 3 melanoma. That is tumors that have spread to regional lymph nodes. And this is a disease that surgery is the very most important treatment. And I can't emphasize enough the importance of the surgeon. The surgeon who treats melanoma should be a melanoma surgeon, someone who is familiar with the natural history and the nuances and the techniques of this disease. The management of the primary tumor requires that adequate margins be achieved around that primary tumor. And most of the time, a melanoma is diagnosed by a dermatologist, and maybe the dermatologist excises that entire tumor, but it's really very important to try to decrease the risk of local recurrence, that there be adequate margins achieved around that primary tumor. Depending upon the characteristics of the primary tumor, lymphatic mapping should then be carried out. And this is done by injecting radioactive tracer at the site of the melanoma and monitoring where it goes to try to identify the sentinel lymph node. The sentinel lymph node is the very first lymph node in a lymph node chain, and the most likely, if the tumor has spread, to be present in that particular site. When the sentinel lymph node is identified, it's then surgically removed and given to the pathologist who treats that tissue in a very special way, namely sectioning the tissue in a very, very thin or much thinner fashion than usual tissue is looked at by a pathologist, and also staining it with special stains, trying to detect individual melanoma cells. And really what is being looked for here are small nests of cells that otherwise would be overlooked in the routine handling of this tissue. If the sentinel lymph node is positive, then the present standard of care is that the rest of the lymph nodes in that drainage basin are removed. It depends, it varies from patient to patient, but at least at this point in time, this is the usual standard of care. Depending upon these things, patients are then evaluated whether they might have identifiable distant metastases with scanning, CT, PET, MRI. Then and only then is there a consideration for adjuvant or quote add-on therapy, because many patients are going to be cured by the surgery, but melanoma is kind of like a dandelion. And I tell patients this is kind of like a dandelion. You can cut the dandelion out, but if the seeds have gone blown out into the grass, the seeds can be there, not visible, and if you could put weed killer on the grass, that would really be great and prevent those dandelions from germinating and growing. And that's what the adjuvant therapy is. So presently, the adjuvant therapy of stage 3 melanoma, high-risk melanoma, is high-dose interferon alpha, which is administered for 12 months. This therapy improves the relapse-free survival in a variety, in almost all the clinical trials that it's been looked at. It's been variable in terms of improvement in overall survival. However, when all the trials have been put together and analyzed in a meta-analysis, it does show improvement in overall survival. And this standard of care really was pretty much established by a series of ECOG or ECOG trials, standing for Eastern Cooperative Oncology Group. These 3 trials, which were actually under the direction of Dr. John Kirkwood, that you'll be hearing from later today. So the adjuvant high-dose interferon therapy that is now the standard of care is essentially the same as that used in the ECOG trials. And this is highest possible tolerable dose given for 5 consecutive days for 4 consecutive weeks, followed by 3 times a week subcutaneous injections for 48 months, for a total of 1 year of therapy. The toxicities from this therapy include flu-like symptoms, gastrointestinal symptoms, nausea, diarrhea, loss of appetite, weight loss, fatigue, decreased ability to concentrate, depression, autoimmune disorders, decrease in blood counts, and elevated liver function tests. And this is not a totally complete list, but I think is a pretty good overview. And the toxicity of this therapy is not to be underestimated. I think one of the important things, though, to understand about adjuvant therapies of any sort is that they improve the risks of the tumor coming back, or any kind of cancer coming back, in general by proportions, that is, by percentages, so that if a patient has a 60% risk of the tumor coming back, they're going to derive more absolute benefit than someone who has a 6% chance of it coming back. The improvement in relapse-free survival with high-dose interferon alpha is in the range of 20 to 30%. And again, by pooling data from a lot of trials utilizing interferon, overall improvement in survival of 3 to 10%. So it's obvious that this treatment is toxic and it's not for everyone. And so a patient needs to really very carefully consider their own situation. Is this kind of potential benefit worthwhile to them in their own context? And, do they prefer to just be monitored because they may very well be cured of their disease without this kind of treatment. And sometimes conceptualizing what a decrease in risk is somewhat difficult because at the end of the day, at 5 years, it doesn't make any difference if your risk is high or low. The tumor is either relapsed or it hasn't. And this is kind of, again, like an analogy to a horse race. The horses are at the starting gate, and one's going to win at the end, another one's going to lose. But you don't know which one it is. They're long shots and favorites. And so getting interferon is kind of like taking your bet from a long shot and putting it on the nose of the favorite. Okay, just in passing to mention, adjuvant therapy, sometimes with radiation therapy in very special circumstances, is used. It does decrease the risk of regional relapses, but does not really have an effect on overall survival. So I'd like now to describe a couple of the active clinical trials that we have here at Metro and other ECOG institutions throughout the country. And this is 1697, which is a study of adjuvant therapy. And as I've just described, the standard adjuvant therapy is interferon, 4 weeks high-dose IV, followed by 48 weeks of subcutaneous 3 times weekly. In looking at this data, some people have felt that the initial 4 weeks of high-dose daily interferon is perhaps the most important part of the treatment to give the kind of benefit that has been demonstrated in the clinical trials. So the currently active 1697 randomizes, that is by flip of the coin, patients who have lower risk melanomas to either 4 weeks of the daily IV interferon or to observation. And the goal of this trial is to enter 1,420 patients. And the accrual is getting there, but is 200 patients shy. Now, there was a study published last year from Greece that was somewhat similar to this trial, but they randomized or had fewer patients. Whoops. Okay. 352 patients who received only the IV interferon, and the other half of the patients received the IV interferon plus the 48-week. That is, trying to compare just the upfront versus the entire year. And this study demonstrated there was no difference in these two groups of patients, those who got the year therapy and those who got the 4 weeks. So actually that kind of supports the idea that the 4 weeks may be the most important and may be adequate. However, this particular study, unfortunately, used a lower dose of interferon up front, about 25% lower dose, and there is a suggestion that the dose of interferon that is given up front is important. And it's not really comparing to observation. So the results of 1697, I think, will be really important because the initial 4 weeks of the high-dose interferon is usually more tolerable in terms of toxicity than the whole year therapy. And if there are improvements in risk that are seen in this trial that would be expected if the 4 weeks of adjuvant therapy was of benefit, one could consider to safely stop or not give the 48 weeks of subcutaneous maintenance therapy. Okay, now we'll turn to the treatment of stage 4 melanoma or metastatic melanoma. And the first comment is that there is no consensus for standard treatment. So I think this should tell you that there's really nothing that has been established that is really terrific. Once again, looking at the available modalities for any kind of cancer, surgery is sometimes of benefit in special circumstances. Likewise, radiation, again in very special sorts of circumstances. Chemotherapy includes a variety of different drugs, although this drug, DTIC, is the only FDA-approved drug. The temozolomide or Temodar is kind of a cousin to this and frequently is used interchangeably. I've also included kind of here between chemotherapy and biologic therapy targeted agents, because chemotherapy agents directly attack and kill the cancer cells, whereas biologic therapy acts in cohort with the immune system of the patient. So targeted agents are very specific agents that attack the tumor, but they're really not chemotherapy in the same sense of causing other side effects or other tissue damage that one may see with standard chemotherapy agents. The biologic therapy include things like cytokines, which include interferon, interleukin-2, vaccines, antibodies such as the anti-CTLA-4, and cellular therapy. And this is a circumstance that a clinical trial, whenever possible, should be strongly considered. Again, because there's no real consensus for what the best therapy is. Okay, so I'd like to describe to you briefly a couple of the trials that we have here at Metro. 2607 is a trial of targeted therapy, and its title is dasatinib in patients with unresectable, locally advanced, or stage 4 mucosal, acral, or solar melanomas. Most cutaneous melanomas, that is, melanomas that arise on most sites of the skin, have mutations in the protein kinase signaling pathway that mediates responses to growth signals. And the BRAF mutation is one of the most common. In contrast, less common and kind of unusual melanomas that arise on mucous membranes, such as in the mouth, rectum, female genitalia, sites of that sort, acral melanomas that arise in palms and soles and other nails, and those that arise in chronically sun-damaged skin rarely, if ever, have this BRAF. Rarely, if ever, have the BRAF mutation. Okay. Okay. In contrast, they have a mutation in the KIT receptor tyrosine kinase gene. The cancer cells with KIT mutations may be inhibited by drugs called tyrosine kinase inhibitors, or TKIs. And examples of successful therapy with TKIs include chronic myelogenous leukemia with the drug Gleevec that has changed this from being almost always a fatal disease to some people being cured. Gastrointestinal stromal tumors or GIST tumors, the same sort of circumstance, And in non-small cell lung cancer, some targeted therapies are highly effective. So patients who actually have proven mutations in the KIT gene have demonstrated clinical responses to oral TKIs. So in this trial, the patients with these specialized melanomas will receive the drug dasatinib, which is an oral drug given twice a day. The goal is to study 57 or 56 patients, and this is what is called a phase 2 trial. So what is being looked for here is whether there's a response. Then finally, 1608, which is a trial that is kind of in the pipeline, not yet available, utilizing anti-CTLA-4 antibody, which I think you're going to hear a lot more about, is a very exciting agent. CTLA-4 stands for cytotoxic T lymphocyte-associated antigen 4, and this is an immune checkpoint molecule that downregulates the pathways of T cell activation, which are the quarterbacks directing immune response. You have to practice. Most people call it IPI, is a monoclonal antibody that targets this particular checkpoint and promotes anti-tumor immunity, and was shown and published with published data that it increases the survival in patients who've failed other therapies for metastatic melanoma. Its side effects are mainly autoimmune, colitis, skin, and endocrine. And 1608 plans to randomize patients who have been previously treated or untreated to the IPI alone or IPI plus GM-CSF, which is another immune cytokine. And I think that you're going to be hearing a lot more about this particular trial. And so I will stop there.